Hello, my name is Gwendolyn Kukel, and today I'll be presenting a brief overview of pharmacology and mental health, covering medication tiers, mechanisms of action, and evidence-based alternatives. This presentation will explain how medications are used across several major mental health disorders and why pharmacological treatment alone is often insufficient. We will also review ethical responsibilities in social work practice and illustrate these concepts through a focused case example. To begin, the goal of this presentation is to review primary, secondary, and tertiary medications commonly used to treat mental health disorders. Again, we will discuss ethical considerations related to medication management and highlight evidence-based alternatives that support a comprehensive biopsychosocial approach to care. To meet these objectives, I'll begin by briefly reviewing medication approaches and alternatives across several major diagnostic categories. Let's start with anxiety disorders. Pharmacological treatment for anxiety typically includes primary medications such as selective serotonin reuptake inhibitors or SSRIs, which increase serotonin availability in the brain by inhibiting reuptake. Secondary options often include serotonin neopinephrine reuptake inhibitors or SNRIs, which act on both serotonin and neopinephrine. Tertiary treatments may include benzodiazepines, which enhance the GABA activity and then provide rapid symptom relief, though they carry risks of dependence. While medication can reduce physiological symptoms of anxiety, cognitive behavioral therapy is a highly effective alternative intervention because it addresses maladaptive thought patterns and avoidance behaviors that medication alone does not resolve. Anxiety disorders illustrate how medication can be effective for symptom relief, but often requires that cognitive and behavioral interventions to address the underlying maintaining factors. And while anxiety treatment often focuses on reducing hyperarousal, bipolar and mood disorders require a different emphasis, particularly on mood stabilization and daily rhythm regulation. So the primary medications include mood stabilizers such as lithium, which modulates neurotransmitter signaling, and anticonvulsants like valproate, and which increases GABA activity and then stabilizes neural firing. Secondary and tertiary treatments often include atypical antipsychotics that act as dopamine and serotonin receptors. And while these medications are essential for managing mood episodes, they do not address disrupted daily routines or interpersonal stressors. As a result, interpersonal and social rhythm therapy serves as an important alternative by helping individuals stabilize daily rhythms and reduce relapse risk. Moving on to personality disorders, disorders further highlight the limitations of pharmacological treatment. Medications such as SSRIs, mood stabilizers, and antipsychotics may be used to target symptoms like mood instability or impulsivity, but they do not address the core relational and identity disturbances that characterize personality pathology. DBT, which is dialectical behavioral therapy, is considered a gold standard non-pharmacological intervention because it teaches skills in emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness, which addresses the underlying patterns that medication cannot change. Personality disorders further highlight the limits of medication alone, and as treatments must address long-standing patterns of emotional regulation and interpersonal functioning. In schizophrenia spectrum disorders, pharmacological treatment primarily involves antipsychotic medications that block dopamine D2 receptors and serotonin receptors to reduce positive symptoms such as the hallucinations and delusions. However, these medications have limited impact on negative symptoms, cognitive deficits, and functional impairment. As a result, Psychosocial interventions such as social skills training and cognitive remediation are essential components of treatment to support the functional impairment or functional improvement and community integration. Even in severe mental illness, medication is most effective when paired with psychosocial interventions, an idea that becomes especially important when considering trauma-related disorders. Trauma and adjustment disorders emphasize the need for trauma-focused care. Pharmacological treatments such as the SSRIs and the SNRIs may reduce hyperarousal, anxiety, and depressive symptoms, and medication like Prozac can be helpful for trauma-related nightmares. However, medication does not process traumatic memories. Eye movement desensitization and reprocessing, otherwise known as EMDR, is a strongly supported trauma-focused therapy that facilitates adaptive processing of traumatic experiences and has been shown to significantly reduce PTSD symptoms. Trauma treatment underscores a broader pattern across diagnoses. While medications may reduce the symptoms, they often do not address those underlying mechanisms of distress. Across all of these disorders, medications are an important component of treatment, but have clear limitations. And it's important to just briefly highlight some of these. So, in anxiety and trauma-related disorders, medication does not address avoidance or trauma processing. And in bipolar disorder, medications stabilize mood, but do not resolve psychosocial triggers. For personality disorders, medication does not change core relational patterns. And in schizophrenia, antipsychotics have limited impact on negative symptoms and functioning. These limitations highlight the necessity of integrated evidence-based psychosocial interventions. Bipolar disorder provides a clear case example of this integrated approach. While medications are often effective in managing manic and depressive symptoms, they do not address daily routine disruption, interpersonal stressors, and adherence challenges related to side effects. Interpersonal and social rhythm therapy complements the pharmacological treatment by helping individuals establish consistent routines, improve medication adherence, and reduce relapse risk, demonstrating how combined treatment leads to better outcome. From a social work perspective, these clinical realities connect directly to ethical responsibilities to the broader society. Under Section 6 of the NASW Code of Ethics, which is the National Association of Social Workers, social workers are obligated to advocate for ethical, evidence-based mental health care, engage in public participation, and policy development, responding appropriately to public health crises such as overprescribing, pill mills, and addressing systematic issues, including pharmaceutical influence and healthcare inequities. Ethical practice requires social workers to promote integrated care models rather than a reliance on medication alone, particularly for marginalized and our vulnerable populations. In conclusion, effective mental health treatment requires a balanced approach that integrates pharmacological intervention, evidence-based psychosocial therapies, and ethical advocacy. By understanding both the benefits and limitations of medications, social workers are better equipped to support that holistic client-centered care and improve long-term outcomes. Thank you so much for being part of my presentation today.